Right. So, in the previous session, we learned about the basics of communication, right? How to talk to a patient. You know, what are the body postures? What are the gestures that we need to adapt or adopt in order to communicate? In this session, we'll be discussing more about how to communicate the pattern. So we have a patient, we know that the condition is deteriorating, or we know that he has been diagnosed with cancer. How to communicate this information to the caregivers or the patient? How to go about it? What are the steps involved in breaking this news, right? So we know that the usual skills required for communication is thinking, listening, speaking, and a larger chunk of the communication is being taken care by the non-verbal cues or non-verbal communication. The verbal words that we use take up only 7% of our communication. The rest of the 93% is taken by tone of our communication as well as the non-verbal gestures. This is just a recap of the previous session. Right. So, why do you think we need to have this included or this module included in our syllabus? Why do you think communication is important? Why do you think communicating bad news is important? Or why do you think communication is such important or should be included in our syllabus? Any thoughts? You can use the chat box or you can unmute and say. I think everybody is just coming into this emotional support. Okay. Thank you, Gitanjali. Any other inputs? Okay, we'll start. Okay, so the main aim of medical communication. So whatever we do within our medical facility or it could be about treatment, it could be about communicating the information, whatever it is. Yes, to find out any issues. Thank you, Benedicta. Concerns to find out to explore more about the concerns from the patient side to or even for our treatment to be better, we need to know what other concerns are there from their part, right? So in order to get more information, so for the first and foremost point is to enhance the therapeutic nature of the medical encounter. See, just by prescribing medicine, see, a patient is coming to you. I mentioned in the previous session also, we are not just prescription minting machine, right? A patient comes to us and we'll be like talking to the patient, and if the patient is here and we'll just prescribe the medicines and everything is done. See, it's more like, what do you say, you are not even looking at the patient. Okay, so how is this going to be how is this going to be effective? So in order to it to be more therapeutic in nature, communication is important to reduce uncertainty and improve outcomes of care. This is like very important. So most of the time, see, we had a patient, I think it was a child. Okay, no, she was a young adult. She was diagnosed with cancer. I think it was stage 3 or stage 4. She had breast cancer. So we see. I was called upon in for intervention because the team that were there found that she was not willing to take medicines. Okay, she did not want to take any medicines or any treatment or any radiotherapy, any chemotherapy. She didn't want any of these. Okay, so she completely was reluctant to go with the treatment. So she was brought in for a conversation with me. So while I was having a conversation with her, it was found that her mother, I think her mother had cancer, and one of her aunt also had cancer. Okay, so one of them took treatment, and the other one, I didn't. I think she did not take the treatment, and both of them suffered a lot. Both of them went through a lot of pain and all. And she felt like, whether I take this treatment or not, I think I am going to die. Okay, anyway, I am going to die. So why should I take this treatment? So I had to sit with her and inform why this is important, why this, so why there is a chance that when it comes to breast cancer, there is high chance that even though there is like what do you say, there is genetic history, everything is there, it is possible that it could be curable, not curable, it could be managed to an extent when compared to other types of cancers, right? So if proper treatment is taken at proper stage, for example in early detection and all, it is like very helpful. So, and later on, she was like, after thinking with this information, she sat for some time and she was like willing for taking the medicines and treatments. She was like willing to try, at least give it a try. So most of the time, what we see is that there is a lot of uncertainty, a lot of ambiguity is there in information. The patient won't be sure, whether to go about this treatment. What is my condition? Where exactly am I? So a lot of confusion is there. What my future is going to be? A lot of confusion, a lot of ambiguity is there. So in order to reduce this, communication is important. Improve patient satisfaction. This was already mentioned in the previous session also. Communication improves a lot of brings about a lot of patient satisfaction, team satisfaction. Even from our side, physicians also, we also get satisfied. To prevent inappropriate hope and guilt. So this also helps in preventing inappropriate hope. For example, they might feel that this might be completely cured. If I take this treatment, it might be I might get cured in a day or two. If I'm a patient with stroke and they believe that, okay, if I take so and so physiotherapy, I'll be like able to run in like maybe 3 months or something. See, a lot of ambiguity, a lot of hope, a lot of false hope are there. So in order to prevent or reduce this inappropriate hope and guilt also, medical communication is important. And also what we usually see is that guilt, when it comes to guilt, we all always feel that we have always seen caregivers saying that maybe I should have done this, I should have done that, maybe if I had done this she would have been better, maybe I should have taken this taken my mother to a different hospital, or maybe should have provided with different facilities, then she would have been better. So a lot of self guilt kind of brings about in this during this time, right? A lot of hope, a lot of maybe I should have done this, maybe I should have done that. A lot of should haves also come up during the stages of treatment. So in order to prevent that also, communication is very important. We need to sit with the caregiver and say like, this is so and so the case. So this is where your amma is, and maybe this treatment could help her, or this is how this is going to be. Like we have to sit with her and explain. The next is to prevent conspiracy of silence. What is conspiracy of silence? Anybody, any idea? Anybody, any idea what unable to express? Right. So, conspiracy of silence, see, this we see in almost all the cases, okay? So, conspiracy of silence means everybody knows what the situation or current scenario is, but nobody is willing to say this out loud. Okay, so I know what my condition is. My parents might be knowing what my condition is. My spouse might be knowing what my condition is, but nobody is ready to come out and say what exactly it is, right? Everybody knows the information and everybody is suffering alone. Getting the point? For example, there is this patient. I'm just taking hypothetical cases, okay? So she is being, or he is being, he is having CER lungs, and he knows that to an extent, even if doctors or the spouse has not informed him, he knows that his condition is deteriorating, and that he knows that he is becoming weak. He may not have much days left. He knows this information. Okay, nobody has conveyed this information to him, but he somehow knows because of his physical conditions. The spouse knows that okay, he is going to be so and so, and she is also suffering alone. So everybody knows the information, but nobody is ready to express this out loud or say this out loud, and everybody is suffering alone. This is what usually happens in conspiracy of silence. But what is needed is that a proper communication has to be channelized between these caregivers and the patient, as well as the physicians who are treating the patient, so that everybody is there. The whole support is there. The support system is much better when you actually talk about this loud, other than keeping everything in mind, right? So here, when I take this hypothetical case, the patient is suffering alone. He is not able to express his grief or his sadness because he feels that if I express this, my wife will be sad. The wife won't be saying the prognosis and diagnosis and the deteriorating condition, communicate won't be communicating the bad news, because she feels that he might become sad, and both of them are suffering in silence. So this is called as conspiracy of silence. This we need to break down so that they are in this together. Okay, it's not just the patient suffering alone, the caregiver is suffering. So both of them are suffering anyway. So it's better if they are together in this, fighting this together, right? That is called as conspiracy of silence. Right. So, what is the impact of having a proper communication? So, we mentioned about the aims, why this is important, and now we are coming to the impact of communication. If it is not proper, it can lead to a range of negative emotions like shock, disbelief, numbness, guilt, etc. in the patient and the family. What happens is that, okay, we might be busy, we might have we might have like 100, 200 patients in our OP. We might be seeing this we might be busy, we might be walking along the corridor, we might be going through the reports, and so suddenly we might be seeing this patient, and we'll be saying that, okay, you have been diagnosed with so and so cancer, the stage is so and so, and we'll just walk by. What happens to the patient when we do this? The whole world comes shattering down, right? Just walking by or sitting down, just informing that, okay, you are having cancer, and I'll just walk by. We are not listening to what the patient wants to say, even before the patient, the caregiver or whoever we are talking to, even before they comprehend or perceive the information, we just threw it like a bomb or bombarded with the information, and we'll just walk by, right? So the whole world comes down shattering to for them. They are in shock, they are in disbelief, they might be angry, they might cry. So we cannot just put the information just like that and walk away. So if the communication is not proper, it can lead to a lot of negative emotions. If done well, can lead to a stronger and trusting relationship between the nurse or the patient, or the physician or the patient. Okay, so this is what the impact of communication is. Right. So this we usually do if this is done in our on-site. This is usually done as a role play and all. Okay. So we'll just read about it. The patient is coming, and the patient is saying that, doctor, I don't feel too good. Okay. So immediately what the doctor is saying is that, you have not followed my instructions. I can see that. See what impact is the patient having here. Immediately the doctor is dismissing his feelings, saying that, so this is why you're not feeling good, because you have not followed my instruction. That how are you going to feel good? We are like curbing. This would curb any further conversation. The patient won't feel like talking to you, right? So if I'm talking to a doctor and I'm saying that, I don't feel good, and immediately the doctor dismisses my feelings, my emotions, and saying, this is why, because you're not following my instructions, and I won't even feel like taking this conversation any further, right? I wouldn't even feel like saying anything at all, right? So, how should we be assessing it? How should we be taking the communication? I can see that too. I can see that you are in pain. I can see very well that you are in distress. See what is troubling you. What is it that is troubling you? This is more like an open-ended question, and this gives space for them to actually say their concerns. This is an open question, may allow easy venting out, and may we can actually assess what the concern is, right? So if a patient is coming to you and saying that he is not feeling good, just acknowledge his feelings first. Okay, you must be acknowledging the feelings first. I can see that you are in trouble. I can see that you are in distress. What is it that troubling you? Simple. A simple question as such would build a very great relationship between you and the patient. Another one, doctor, I'm unable to sleep at night. So patient is coming and saying that, see, I'm not able to sleep at night. And immediately what the doctor is saying that you must be sleeping during the day, or take diazepam tabs, and you should be sleeping well. Is how will the patient feel? Immediately the patient's feelings, emotions, there might be a thousand reasons, multiple reasons why he is not able to sleep. Is it just because he's sleeping in the afternoon? See, that could be one of the many reasons, okay? But you cannot just dismiss his emotions just like that, okay, just by saying that you must be sleeping during the day. See, we are somehow putting the blame onto the patient, which shouldn't be the case, right? Reasons for sleeplessness nights may be more serious instead. What if he is having suicidal ideation? What if he is having anxiety? What if he is having panic attacks? What if he's having concern, uncertainty about his future? A lot of reasons might be there. It won't be just sleeping because of sleeping during the afternoon, or you cannot just say that, okay, take some diazepam tabs and you will be fine. How should be the conversation be done? I understand it must be frustrating not being able to sleep. What has been troubling you? What are you thinking of? What are the thoughts that are coming to you, or what are the physical feelings that you're feeling? Like, are you agitated, or what is it that you're really feeling at night? It is an open question, and from there the patient will be explaining why, as of why he is not able to sleep. What is it that really bothering him or her, right? So, breaking bad news, BBN. As I said, we have like come over the use of BBN to more like communicating bad news. So it is any information which adversely and seriously affects an individual's view of his or her future. So this is any information which is going to change his or her life, right? His or her perspective of life or perception of life is going to affect him completely. Okay, it's not a very good thing that you're going to say, right? I mean, it could be a good thing also, but mostly when we do in our medical communication, it's somehow going to affect the person or the patient, right? So breaking bad news, BBN, is any information which adversely and seriously affects an individual's view of his or her future. Okay. So, right, you can see two eggs being broken. Can you like say the differences between the first and the second picture? Chat, you can use chat box. You can unmute yourself and say anything. So, what differences do you find from the first picture and the second picture? It's just like breaking an egg, okay? But what's the major difference that we see here? First one is very messy. Thank you, Annamal. It's very messy, right? Any other inputs?
Second one is a perfect bullseye.
Its second one is a perfect bullseye. Thank you so much, Rosamma. First looks messy. It can't make anything out of it exactly. It spreads. We should open the news clearly. And the second one is neatly broken. Thank you. Right. So even when it comes to egg, we can do it in two ways. Okay. I can either in the first picture, as many of you have mentioned, it is completely messy, right? There are a lot of cracks. The yolk is like spread everywhere. It's a complete mess. But when you look at the second thing, it's perfectly broken into two. And as Rosama has mentioned, it's a perfect bullseye, right? Right. And in order to break an egg, it requires certain skills. Just like that, breaking bad news is similar to breaking an egg. A certain amount of skill is needed, otherwise, you are liable to make a mess. This is a quote by Peter Kay. So either you can have a very neat communication, a very neat way of breaking the news, or you can make a complete mess out of it. This depends completely upon how you are going to break the news, right? And it is also you have to also make it a note a point here, right? That a lot of other people are also involved in here, right? You're not just breaking a trust, or you're not just breaking the news to patient, but the caregivers are also involved. A lot of relationship is involved, right? So when you're breaking it, you if it's going to be a complete mess, and multiple layers, it's not just a patient a physician relationship. It could be patient and the relatives or the caregivers relationship. It's under multiple layers. You are going to make a mess. But if done properly, it's going to be a very good, and I mean, it's going to be very satisfactory relationship that you are going to have, right? So it's a skill, and as we mentioned in the previous session also, it's a skill that we need to cultivate. It's something that we learn. It's not randomly that is happening. You need to start cultivating, only then through experience, through skill training only it is going to happen, right? Right. So you are a GP, you're a general practitioner. This was actually made for doctors, okay? But you can consider yourself in the position. So you are a GP. You have seen a patient about a week back for mouth ulcer, but the patient did not respond to your treatment. So the nurses here kind of prescribed some medicines, and they did not respond to the medicines. You advise him to go to a surgeon who then did a biopsy, Patient has come to you with a biopsy report which reveals cancer. So, how will you disclose? A patient under your treatment did not respond to medicines for mouth ulcer, and you advised him to see a surgeon, and the surgeon from there asked him to do a biopsy. The patient came with the biopsy report. So what is it that you're going to do? How are you going to break the news? Anybody, any idea? Yeah, sure, please go ahead. Hello? Hello? Is someone saying something? Any idea how you're going to break? Just from your experience, see, it's okay even if you're wrong, okay? So this is how we are going to learn. How are you going to communicate the report to the patient? At least what are some of the ideas that you have?
We have to ask the family also to be present, because directly if he tell the patient may not be feeling okay.
Right. Thank you so much, Rosama. There has to be like family involved, people involved, whoever the patient is very close to. Okay. It could be friends, it could be family, it could be spouse, it could be children, it could be anybody. Okay. So generally, how you might have seen doctors giving these reports, right? Ask the patient about the report. Thank you. Right. Hi, Twinkle. Right. So,
Hello, good afternoon.
hi. Right. So, I'll just go about. Okay, these are some of the ways we usually see our doctors responding. Okay, so your report says that you have cancer. You better get admitted and let's see what treatment is feasible. Is this the right way to answer? Is this the right way to go about a patient who has, who has no idea of whatsoever is happening around the patient, right? Whatsoever the report is, right? This is what we usually see. See, it's not generalized one, but at least where there are like a busy OPDs, there are like the doctor is very busy, have like 200, 300 patients waiting for him. This is how we usually see, right? The second response, I'm sorry, you have been diagnosed with cancer. Perhaps it has already been advanced, and I guess we don't have much treatment. And I'm afraid you only have 3 months to live. Is this the right way to answer? Patient is upset and he's feeling lonely. He the entire world collapsed in front of him, right? The complete every door is kind of closed around him. He does not know what to do or how to do. The patient is shattered. So, right. Why? I'll come how to go about it in the few steps. Okay. Before that, this is a role play that is done before the how we learned how to break the bad news. Okay, and then we'll have a role play again, and then I hope at least some of you will come up with how you're going to break the news. Right. So, why is this communication difficult? Why is this breaking bad news or communicating bad news difficult for us? First thing, I think somebody already commented in the chat box, I guess. Chat box. We need space, we need privacy. We should, thank you, merciful summer, right? We should give some privacy, talk to the patient and relatives about the disease and ask if they can afford for admission or treatment. Thank you so much. So the first, there are a few environmental barriers that are there, which makes a communication process very difficult. So the first one is space. I'm just walking around the corridor, as I said, mentioned earlier, and I'm just informing them, okay, you have been diagnosed with cancer. The report says that you have cancer. Maybe you should start taking chemo and radiotherapy from the next week onwards. We cannot just randomly say things and just walk by, right? We need space. We need privacy to sit with the patient and talk to the patient and address his concerns. External interference might be there. There might be phone calls. There might be crowd. There might be noise around you. So that is how the usual hospital settings are, right? So there might be 100 things happening around you, and you just inform the patient that, okay, you have been diagnosed with cancer, so and so, the stage is so and so, and you just walk by, leaving the patient all alone there, right? and you might be using a lot of medical jargons also. So this might completely confuse a patient. This might completely make him feel lonely, isolate, like he won't have any idea of how to go about it, right? So these are some of the environmental barriers which makes the communication process difficult. Why is it difficult for the patients or the family to communicate properly? Because they feel that always, whenever we take the patients, our patients cases, we feel that the patients feel that the doctor is of some higher authority. Okay, they have some higher power over us, right? That's what we usually see in our patients, right? They feel that the doctor is too busy, they do not know how to ask. They feel that, okay, if I ask this question, see, already the doctor is very busy, he has like so many patients waiting up, and if I ask this question, I don't think he might have time to explain this. So the patient will not feel like having the communication. Fear, what the patient does not have a proper communication of fearing the answer, fearing the response. What if they say something and that information I won't be able to take it? What if they say that I have cancer? I may not be able to digest the answer or digest the fact, right? So fear of the answer is one reason why the patient is not communicating properly. The patients feel that doctor is more interested in the physical care and do not want to know of their emotional problems. So that's the usual ideas that the patients have or the caregivers have. They feel that, okay, see, doctor is here to know your physical symptoms and manage the physical symptoms. If I say my emotional concerns and my fears and whatever I'm feeling, I don't think the doctor will be interested in those facts, right? Frightened of breaking down in front of us. They have this feeling, okay, I'm coming to a doctor with a report, and if they say something which may not be a very good news or something, and what if I break down in front of them? So I'll just better not ask at all. These are the barriers that the patient is having, right? The patient feels that if I ask this and say, and the doctor explains the report and the doctor says that I'm having cancer, what if I cry down? What if I cry? What if I burst out my anger? What if my emotional things that I have been keeping close come out all of a sudden? Better I won't ask itself. That's better way of dealing things. I won't ask itself. So these are the barriers. Second, last thing, if they demand more clarification, doctor will stop treating them. So these are the ideas that the patient is having. What if I ask more doubts? What if they feel like, I'm being like a pain, like I'm being so much irritating for them? I'm asking so many concerns, so many questions to them. What if they feel irritated, and what if they stop treating me at all? These are the concerns that the patient is having. And what are some of the barriers from physician side? What are some of our barriers? Why do we feel like not breaking it as physicians or nurses? What is it that is causing you not to say it?
We may not be knowing the disease condition properly.
We may not be having a
Proper
knowledge,
knowledge.
proper knowledge won't be there. Then
Yeah, can be that also. Then language which is known to the patient.
a language barrier might be there. Anything else? Thank you, Philomena, for your message. Communicating bad news. Okay. Anything else? What are the barriers that we as physicians face? Lack of facility, lack of time. We don't have a proper space. We don't have proper time to sit with the patient and speak. Anything else? Less time. Thank you. Right. Anything else?
Sometimes patients, all the relatives may not be available to break the
The
news to.
relatives may not be available. Okay. Most of the time, what we feel is that, they kind of start blaming us. Don't we feel that? Have you seen that in your experiences anywhere? They start blaming you. Inability to explain in layman's term. Okay. See, we had a patient. Okay, it was a child. The sibling, the child was our patient, and he kind of passed away. And the sibling was there who used to come and see the child every day. Okay, see his brother every day, and suddenly the child kind of started throwing tantrums, and the child kind of started throwing tantrums towards the. I think it was myself was also there. A duty doctor was also there. Okay, because we were mostly in charge of the patient, of the child, and he suddenly started throwing tantrums because he somehow felt, that we are going to take care of the child and we are going to bring him back to home. And this anger was there, the anger was there, we tend to feel like, what if they blame us, what if they and also I will come to each point. Okay, it might hurt the patient. Thank you so much. That is also one of the reason. First one, for professional, fear of getting blamed. Most of the time, we are the ones who are going to inform them that, the patient you're having so and so. It could be either a nurse, it could be a psychologist, it could be a doctor. We might be having the report, and mostly it could be physicians and nurses. You people might be informing that, you are having so and so issue, and the stage is so and so. So most of the time, we feel like, okay, we are like letting the patient down. We are like, we are not we are not bearers of good messages, right? We are somehow giving away a very bad news, which we don't usually feel like doing that, right? Do we feel like, taking away like bad news to them? So we usually feel this fear
With
of
all,
sorry.
sorry.
Okay, no issues. Fear of getting blamed, letting the patient down. What if the patient asks difficult questions? Will I have enough answers? Like someone already mentioned, lacking proper knowledge. What if the patient and family starts crying suddenly? Will I be able to manage their information? What if they suddenly start crying in front of me? So these fears kind of are barriers from our side, from our end, from our physician's end to communicate properly. What if they get angry? How will I manage their anger? What will I do? And especially in Indian culture, we have seen those cases where, they even burn up the hospital if at all something happens, right? You might have read in news and all, the caregivers or the people, the family people, like, killing the doctor, killing the nurse, burning the whole hospital. There are a lot of things when it comes to patient treatment. Also, to an extent, wanting to protect the patient. This was already, I think, mentioned by Shiny Thomas. I think it might hurt the patient. We feel like this information will hurt the patient, and I won't say this information personally, I won't say this myself, because I feel like protecting the patient. Anyway, she is doing fine, she is happy, why should I just break this information to her, right? So wanting to protect the patient. How do I reveal a bad diagnosis to the patient? Feeling awkward, powerless, and embarrassed. Most of the time, we feel embarrassed. We feel powerless. We cannot help the patient, and we feel helpless. There is nothing more from our end to do. So to inform this information, we feel bad about ourselves. Not enough time, exactly. We already mentioned that. Being reminded of human vulnerability is something else. Everything is suffering, all those things. The family does not want me to reveal it to the patient. So this is also usually seen in our OP, right? The family members or the caregivers might be knowing that the patient is in the stage 4 or is in EOL, but the family members won't give us consent to break the news or communicate the news to the patient. Have you seen cases like that? We usually see there, right? The spouse will be saying that, anyway, she's doing fine, why should we just inform this news to her and, break her confidence, or, make her depressed, or like something like that, right? So a lot of things are there which is a barrier to us. So what we do usually to avoid this communication part, these techniques that we usually adopt are known as distancing techniques. Okay, distancing techniques. Non-verbal, poor eye contact. So I'll just walk away with the file and say, okay, you have been diagnosed with so and so cancer. Better you get treatment. So I will avoid eye contact, distancing myself. Okay, these are some of the distancing techniques which we unknowingly adopt to not to have a communication with the patient, to prevent the communication from happening, or to prevent the anger from happening, to prevent the patient emotions from bending out, or from showing our emotional part to them, right? Poor eye contact, always busy. I'll just walk around with a file reading. I'll just take a mobile and I'll just say that, okay, you are having so and so, and I'll just walk by, so that in order to avoid that communication properly, my facial expressions will show that I'm not interested. My tone of voice would be different. Concentrating on physical tasks instead of actually saying about what the condition is, what the patient's condition is, what he or she is going through. I'll be just doing some file work, I'll just signing some papers, I'll just typing the medicines, intenting the medicines. I'll be involved in a lot of other activities than actually having a communication thing. This techniques that we take up unknowingly is known as distancing techniques, done knowingly or unknowingly. Okay, So categorizing and labeling as she is a very difficult patient, I cannot manage her. She is usually like that. Her personality is like that. So it's better not to have a conversation with. Never inquiring beyond physical symptoms. So what I will do is that instead of going into that emotional side, I'll just stop my questions with the physical side. I'll just ask, okay, how is your sleep? Okay, how is your appetite? Are you taking meals every day? Okay, fine, that's it. How is your pain? Okay, so and so. Okay, fine. Chalo, bye, goodbye. This is how we usually limit the conversation. Instead of what if I ask an emotional question, what if they break down? So we'll just keep our questions to the physical symptoms, never inquiring beyond the physical symptoms. For example, how are you feeling? Right? This is more like a personal emotional question. So we won't go into that area, and for distancing ourselves, we'll just keep our questions to the physical symptoms. Right? Using leading questions, we already dealt with this in the previous session. We'll be asking leading question like, your pain is better, isn't it? Like, we are already implying the answer in it. So even if the patient is feeling not good, or even if the patient is having pain, the patient will be like bound to say, yeah, I'm feeling better, even if that won't be the case. Premature reassurance, like, giving false hopes, like, don't worry, I will handle it. You don't know whether you will be able to handle it or not, right? It's like giving false hope. Never say don't worry and I will handle it. Speaking too little or too much, that is also a way of distancing technique. I won't use any verbal words or anything like that. I'll just my everything will be like in a hush bush thing, everything will be done in a rush, or I'll be like speaking a lot. See, these are the distancing techniques. Inappropriate humor. I don't know if you have seen it. We have seen physicians who just use inappropriate humor to lighten up the moment, but that won't be needed in that case, right? So these are some of the distancing technique that we take up in order to avoid communication, right? But why it is important to learn how to communicate bad news or break bad news? To maintain trust, to prevent inappropriate hope and guilt, to allow appropriate adjustment, to prevent conspiracy of silence. Again, everybody is knowing what the condition is, everybody is like suffering alone. In order to avoid this, in order to bring everybody on the same page, this is important. As I said, to prevent inappropriate hope, a lot of false hope will be there, everything will be all right, and a lot of guilt will be there. I should take her to this hospital, and this hospital like provides the best facility, has the best facilities. Maybe I should take my mother to there. A lot of guilt should have are there. In order to prevent these, you need to sit with the caregiver or the patient and communicate bad news or whatever the information is. So, what are the 6 steps to breaking bad news? We'll come to spike. This is what the whole spike is. But before coming to the mnemonics spike, I'll just start with each of these steps. Okay. The first one is getting started. Next is find out how much the patient knows. Third one, find out how much the patient wants to know. Fourth one, sharing the information. Fifth one, responsibility to the patient's feelings. And sixth one is planning and follow through. We'll be looking at each point in detail, right? So we'll start with getting started. So before breaking the news, you might need to have an idea of what you are going to say, right? You cannot just randomly go and have a conversation. You must be prepared of what you are going to say. For example, if a patient is coming to you and you are having certain ideas of what the condition is, at which stage she is, if whether she needs chemotherapy, whether she can go with radiotherapy, whether she needs to take tablets, the entire condition, the entire case study, you need to have an idea, and you need to prepare what you're going to say. You can't go there and just say something, blurt out something and come back, right? So you need to have a plan on what you are going to say. So ask appropriate questions. Plan what you will say. Ask appropriate question. For example, how are you? What did the doctor there say? I think I remember you went to the surgeon and you did a report. You did a biopsy. What did the report say, or what did the doctor there say to you? Like that. Create a conducive environment where everything the patient is comfortable. There is no much other hindrances, obstacles are there. There is a like free flow of communication. Allowed adequate time. Make sure that you have time for this. See, I know that it won't be possible in OPs where there are like many patients. At least, see, the very idea is, to get everybody on board with this, the skill of breaking bad news, so that you're not overburdened with work, so that you have adequate time. At least your colleagues have adequate time. There are like, have you just have enough people in your team to do this also. It won't be possible to sit with each patient. But breaking the bad news, it's not that frequent, I would say. I don't know to what extent it would be frequent in your. It is frequent, but you can spare like half an hour, 1 hour for this, right? Or else, breaking bad news takes time. It takes about a lot of time. It needs adequate time. So make sure that you have time before you do this. Determine whom to involve. Like somebody mentioned, you need to have an idea with whom all to involve, whether the son has to be called in, whether the spouse has to be called in, whether the parents had to be called. You need to have an idea of who are going to be there in this conversation. So this is the first step of breaking bad news. Getting started. Plan. What will you say? What are the questions you are going to ask? Create a conducive environment. Allot adequate time. Determine whom to involve with, whom all to be involved in this communication. Okay. Once you are prepared with this, we'll go into the next step, that is knowing how much the patient already knows, right? So we need to have an insight into what we need to have an idea of the patient's insight about the disease, what the patient already knows. So establish what the patient already knows about his or her condition. So usually what we use is that, you can start with, what did the doctor there say? That is how you usually, but even if you have no idea, the simplest way of starting a conversation is, can you just explain me how it all started? From when it started? Can you just say how it started? How was this whole thing started? How this whole thing started? It's more like an open-ended question. So the patient will start narrating. The patient, I was having a leg pain, and I first it was first everybody thought that it was vitamin D deficiency, so I had to take a lot of vitamin D supplements. The medicines were not working, so the patient will start saying a lot of story behind how, the entire thing. So establish what the patient, see, this is done in order to know the patient's insight about his condition. Assess ability to comprehend new bad news, give them the option. For example, we need to know whether they will be able to comprehend, or whether they will be able to take up the bad news, right? So know whether they will be able to take up the news. I would like to talk about, what the doctor said there. I would like to talk further more about it. Right. So we need to have an idea of whether the patient will be able to take up more bad news. The report is saying that, it's not very favorable from our end. I would like to talk more about it. Would you like to know about it? Is it the right time to talk to you right now about the same? We are like, asking, we are just looking at his emotions and comprehending whether the patient will be able to take more bad news, or more bad news, or will be able to comprehend or perceive or bear the news. Okay, we need to assess that. Once we know that, the patient is somehow ready, uh, next be the thing is, we need to know how much the patient wants to know, and then these information should come from the patient side. Okay, recognize, support various patient preferences. People hand information very different. See, every patient that you're going to break the bad news is not going to respond in a similar way. Everybody is going to respond in different ways. Okay, so there is something called as a warning shot. For example, we'll be like saying, see, your report, the what I'm going to say may not be much in your favor. It's showing that it's not something very favorable in your side. Is that okay? Is it okay if I say about this? Do you still want to know more about this? You are inviting the patient. The warning shot has been given, so the information, we have silently implied that what we are going to say is not so very good thing, right? We implied that, and then we'll invite the patient, whether you want to know, whether you still want to know. And if a patient is saying no, we'll stop then and there itself, right? If the patient is saying, I don't want to know much about this, we'll just leave it there. But if a patient is saying, even after giving warning shots, if the patient is saying, I know it's going to be bad, but I would still like to know about it, then we go about it with further information. Okay, right? So warning shot has been given, and the patient is saying that okay, we invite the patient and we get the patient's consent, and then we go about the next stage, that is sharing the information or whatever the knowledge that we have. But whatever we are saying should be very factual. We shouldn't give any falsehood. So whatever we are saying has to be in a very gentle, very slow manner. Okay, it's not something that we do very abruptly and we'll just say and go, right? So it has to be very gentle. Take as much as time as possible. Look at the patient's emotions. Make sure that we give them to express their emotions also. They might cry in between, they might burst of anger in between, but give space for that also. Say and then look at the patient, comprehend his emotions, look at his emotions, stop and then proceed again, right? That's how we usually do it. Say it, then stop, check what the patient has understood. You need to make sure that you both are in the same page. So you need to check what the patient has. Do you like, what do you make out of this information? So what do you think of this information? It is possible to explore concerns while giving information. The patient might have a lot of concerns, lot of questions while doing this. So we might need to address that also. Pay attention to emotions. Whatever emotions are, they might be crying, they might be bursting out in anger. So whatever the emotion is, pay attention to that also. Painful concerns may remain invisible. They need to be propped. What if they have any other issues? You need to be explored. Be clear, be gentle, and the whole conversation has to be very slow. Don't minimize the severity of the disease condition. Never ever minimize the patient's disease condition. Never say, okay, it's just a slight thing that you're having. Don't do that. See, whatever you're conveying should be factual. Never minimize the severity, whatever intensity, with whatever intensity the patient is sitting in front of you, you have to exactly say the same intensity, but in a very gentle way, right? Am I getting? Right? Am I going too fast or the pace is fine? Anybody, any doubts still here? Thank you, Tinkle, for the response. Anybody else? Any are we okay? Right? We'll move about. Thank you, Rosama, for the notes. The non-verbal cues are helping me in some way. Okay, right. So responding to feelings, effective responses are those responses that are overtly seen. It could be crying, it could be the anger, whatever it is. We need to respond to the feeling. We might need to pat. We might need to acknowledge the feelings. Cognitive responses, the thoughts, the thinking process, a lot of thought process might be there, a lot of doubts, a lot of uncertainty might be there, which we might need to address. Basic physiological responses, for example, sweating, palpitation, something like that, anxiety, panic attacks, if at all anything there any emotional reactions comes over, you need to address that. You need to, ask the patient to relax, calm down. You need to in between ask question whether you are okay with this, shall I go about the information further. In between, you need to have this feedback and question the patient. Give time to react, listen. A lot of non-verbal communication takes place at this point. Planning and follow-up. So what follows next? Once the patient and the caregivers, we had this conversation, plan for the next step. So next we'll be discussing how to go about this. So this is how the condition is. This is how where you are. This is the stage where you are at. So we might need to do so and so. You might need to take up 12 cycles of chemo and 12 cycles of radiotherapy or whatever it is, whatever the plan is. You might have to be admitted in our IP or whatever the plan is. Plan it. Discuss the potential sources of support. So this is going to cost you so and so, whether you have so much support, whether you are financially stable for that, or whether there like any other family support is there. You might need to have a caregiver along for an IP admission. Is there any caregiver? There might be a lot of question that we have. Give contact information. If at all there is any doubt or clarification, you might need to call me in this number, right? So this is a whole thing, okay? And this is usually called as Spikes protocol. S is for setting up. That is, we are like preparing, planning what to say, how to say. Perception, At the perception stage, what we do is that we get to know the patient's insight, right? The patient's insight is being taken up at the perception stage. The third is invitation. We invite the patient. We give the warning shot and we'll take consent of the patient. See, whatever we are going to say is not so favorable, is it's something, the implied bad news is there, the warning shot is given, and we take the patient's consent. That is invitation part. Knowledge is where we actually share the information between the patient and the caregivers. Emotional is the responses that they give off. It could be crying, it could be anger. And the last stage is strategy or summary. This is the plan that we have. We need to take up so and so treatment. We need to take up so and so things. So this is how the whole thing is going to be. This is how the treatment plan is going to be. So everything is done in the last stage, strategy and summary. So this is the spikes protocol, which we usually do to communicate bad news. Setting up perception, knowing what the patient already knows. Invitation, giving the warning shot and inviting the patient for the information, to giving of the information. Sharing the knowledge, addressing the emotional responses. Strategy or summary. Objective is gathering information from the patient, transmitting the medical information, providing support for the patient, eliciting the patient's collaboration in developing a strategy or developing. That are the objectives of these steps. Any doubt till now? So, usually in Western countries, what we usually see is that the communicating bad news can be done directly to a patient. Okay, that is how the Western people do. But when it comes to Indian context, in an Indian culture, the caregiver's consent is must, right? Because we have a history of, what do you say? For example, we know that this patient is in deteriorating condition, he is in last stage and might dies. We know that the patient is not having much days, and we break the bad news directly to the patient. Okay, if that is the case, what happens is that the patient suddenly deteriorates, becomes depressed, or commits suicide. What we usually see is that the caregivers will blame the doctors, blame the hospital, call the news people, or put in social media. A lot of mess is usually created. So what we usually do in our Indian context is that first we take the consent of the caregiver. So first we will be breaking the news to the caregivers. We will be sitting with the caregivers and telling them so and so is happening. So but why it is important to convey to the news to the patient, why it is important, why there might be a lot of unfinished business with the patient, right? There might be a lot of unfinished business. The patient might have a lot of wishes or something like that. We never know. So we might need to sit with the caregivers and say the importance of breaking or communicating the bad news with the patient, why it is important. And only after getting their consent only we will be disclosing the information to the patient. And there might be cases, we had cases where the caregivers say that please don't say the information to the patients. And if they are insisting of not breaking the bad news or not communicating the bad news, we won't go forward, right? Only if we have the caregiver's consent, we'll be like breaking the news to the patient. And there is also this thing that right, I will explain the fourth objective. Okay, we have also seen that the caregivers completely rejecting the idea of communicating the bad news, but the patient badly wants to know his prognosis. Okay, we had cases like that where the patient knows, see, whatever happening is this, I know that my body is getting weak, so I know certain things, it's not very good, but I would like to know. And if the caregiver saying is no, don't say, but we'll sit with the caregivers again, like the patient is already having so and so conflict, the patient already knows certain information, again we will be like reinforcing. We'll have multiple sessions with the caregivers and get their consent. The patient's consent is of high importance, obviously, but care has to be taken with the caregivers as well. The fourth objective, sharing the information, I guess, right, Elsama? Right. In the fourth objective, is it the fourth objective? You are all in the slide, in the spikes protocol. Elsama? Can you say the slide number? Is the spikes protocol slides objective that you're talking about, or is it the fourth point that you're talking about? If it's a fourth objective in this slide, then I would say that this is where we sit with the caregivers and the patient and we derive a plan. What treatment has to be taken, how much treatment, what medicines has to be taken. The whole treatment strategy is being done at this point. That is in the strategy or summary part, eliciting the patient's collaboration in developing a strategy or treatment plan. What if the patient says that he does not need allopathic treatment and he needs Ayurvedic treatment? We cannot say anything, right? So we might need to sit with the patient and know what his needs are, what his beliefs are, whether he wants to go along with the treatment plan, and then we'll be like sitting with the patient and having a strategic plan of the treatment. Am I clear? Did I make that point clear? Elsama Joseph, Sister Linda Jose, please do use the chat box, okay? Or else I'll come to that again. Please do let me know. Right. So we'll go along with collusion. It's a very small topic, right? Am I clear till now? Any doubts? If at all there is, please be open, use chat box, or you can unmute yourself and say, I'll come back to query again by the end of the session, okay? Right. So what is collusion? Collusion is basically withholding information, right? Withholding information from the significant person. So information about diagnosis, recurrence, prognosis in the advanced terminal stage of disease and medical details about the deceased person is usually withheld from the patient or the significant person. And collusion is usually done as an act of love. For example, see, anyway, she's doing fine, right? Then why should we just break this news and let her know that her diagnosis is poor and, make her feel bad again? We'll just let her be how she is. We usually do this as an act of love. We withheld information as an act of love. So collusion can occur between professionals and relatives. For example, physicians might withhold the information from the relatives. Sometimes the relatives might withhold the information from the patient. Sometimes the relative might withhold the information with other relatives. Multiple levels collusion can happen. Okay. So I know for a fact that, so and so condition is bad or so and so things are there. I might withhold this information from the relatives. Or the relatives, I might sit with the relatives and I might explain everything to the relative, but the relative might withhold the information from the patient, right? Why should we just, bother her, why should we just worsen her condition? We'll just keep the information within ourselves. Usually done as an act of love. Basic reasons for collusion is usually done with good intention and in good faith. Okay, it's never like, okay, I won't give up this information in an angry way. I won't give this, I won't say this to my spouse because I don't think he'll be able to take it. Or, why should I bother him at this stage? I'll just let him be however he is. I won't say that his condition is deteriorating or whatever news is. Love and will to protect from emotional and psychological distress. So we have this like emotion, right? We have this love and we need to protect the patient or the spouse from all the bad things that bad emotion that he is going through. And I won't just say this information. These are the usually reasons for having collusion. So collusion is usually said as positive, collusion positive and collusion negative. Collusion positive when the information is withheld. So we have this patient and the patient does not have any idea of his disease condition or his prognosis. We'll write as collusion positive, right? And if the patient has an idea of what is, we won't be mentioning either, or else it would be called as collusion negative. But usually it's called as collusion positive. Usually we have a patient file and above that we'll be writing, collusion positive. If it's with the caregivers also, we'll write collusion positive with the caregivers. Okay, it could be positive, collusion positive or collusion negative. Collusion positive, the collusion is present there. Okay, the emotion is withheld. So fear that the patient may give up and die if told the truth. So what are these are one of the reasons why we withheld the information. Fear that the patient might give up, fear that the patient might commit suicide if he comes to know about the information. And I, if told the truth, believe that the patient may not be able to cope with the truth about poor prognosis. So we assume that the patient won't be able to take up the information. We assume they won't be able to take up the information, and then we'll withhold the information, right? So these are the reasons for withholding the information. Some of the other reasons for collusion, there could be a lot of property dispute issues. There might be a lot of property, and there might be division of property, etc. So I'll just keep the information with myself. Let the person die, and I will get all the I will get all the property, all those things. They're like multiple levels. Concern about causing trauma to relatives. Example, okay, if they are having very old parents, if they are very old, they are having a lot of health issues, they are having hypertension, they are already taking diabetes tablets, so there are like a lot of medical conditions attached. Is the caregivers or the parents are very old, is undergoing is going through frailty, and they won't be able to withstand the information, right? So we'll just withhold the information, we won't just disclose the information. So these are the reasons for collusion. a lot of a lot of times collusion happens because of social stigma. What if they comes to know about this? This was also there during COVID, right? You won't say that you're COVID positive, because suddenly people will start behaving very differently, right? What if I say I have AIDS? People will start behaving differently, so I will just withhold the information from the other people. These are some of the reasons. Even cancer, to an extent, I have seen people believe, if they don't come from a very literate background, and all, they feel that this kind of spreads, right? So we had this patient who is having TB spine. Okay, usually TB spine doesn't spread, but there was a home shelter home that we had to communicate, because he does not have anybody else to take care of him. But they feel like this will spread. A lot of time, because of stigma, social stigma, informations are withheld, right? Ignorance and lack of awareness, it is another reasons for withholding information, or reasons for collusion. So this is usually done as an act of law, because we need to protect our patient. We feel like the patient might give up, we feel there might be a lot of property issue, etc. We feel like it might cause trauma to the people who we assume a lot of things, right? We feel it could cause a lot of social stigma. So these are the reasons. But what are the effects of collusion? What happens when we withhold the information? Honest communication is hampered. So the honesty, everything is broken, the trust is broken. Elevated emotional and psychological distress. For example, I'll just say this was a very a case which is very close to me. There was this patient, she had osteosarcoma in left uh, pelvis. Hemipelvectomy was done. She was just 23 years old, and hemipelvectomy was done on the right side, and suddenly she had this pain in her left leg. Okay, so she always wondered why I'm having this pain in the left leg. So the parents took her to RCC, the regional cancer center that is here, and from there it was informed to the parents that the cancer has spread, it has reached metastasis, and it has now spread to the left leg. But this information was withheld from her. So in the first admission, she was able to sit in wheelchair. She was able to sit and do a lot of craft work and all. She used to do a wonderful craft works and all. She was very creative. But in the second admission, we could see that the pain had like reached all over the hip area, and she was not able to sit. Even the slight movements would cause lot of pain in her. So she was completely bed bound. Only slight movements with the hospital bed was possible. Okay, and towards the end we came to know that she was reaching her last stage, and her condition was deteriorating. This information was already given to the parents, and we had multiple sessions with the parents to break this news to her, but in no way they were willing, right? But in the second admission, when we like had multiple sessions, towards the end they become somehow convinced, they gave us consent to break the news to the patient. At this point, the patient has reached a point where she used to throw a lot of anger tantrums. Okay, most of the anger was focused towards the mother. The end point was the end point was the mother. She used to shout, she used to scream. A lot of anger kind of started bringing up from her side. So we sat with the mother and we told her why it is important and all. So the mother said, "Okay, I won't break the news. The team can break." Okay, so the psychologist was there, doctor was there. We sat with the patient. This session alone took, I think, 1 hour, 1.5 hours to break the news to the patient. And after breaking the news, we told that, the condition, her stage, everything was told, and that she won't be able to sit again and all. Every information was given. She did not talk to the parents for 3 whole days. She completely muted herself. She completely stopped having conversation with the parents. So the only people she used to talk was myself and another doctor. Like she had like preferences and all. So even in my sessions she used to say, I had asked my mom multiple times whether like there is something wrong with me, whether it has spread, but every time they keep saying there is nothing wrong with you and that everything is going to be all right. Why did they do that? This was the first thing that she asked me. Why did they do that? Why did they give me false hope? Why did they do that? Why did my mom, of all the people, why did my mom keep this information? See, what was happening was that she already knew that, her condition. See, our body, see, better than anybody else, we know, right? So we know when our body gets weakened, right? So she knew that something was happening with her. Her left leg also started aching like anything. She knew that a lot of inner conflict was there. Like people around her were saying that you are going to be all right, but her physical condition was saying exactly opposite. Her physical conditions were saying that, she was weakening, but her mother and her father around her were saying that, you are going to be all right. A lot of conflict comes up when things don't things are not congruent, right? So after 3 days she started talking with the mother, and her anger completely subsided. All she wanted was to see her siblings. There were a younger brother and no elder brother and a younger sister were there. She wanted to see them, and her anger, everything kind of came down. She it took some time for her to accept. She was in denial for a few days, like the 3 days that was happening, and then she kind of accepted, this is how it is going to be. And that was one case where this collusion thing was, we have seen, this conflict within the patient. So a lot of a loss of trust usually happens when collusion is positive. Anger, guilt, frustration, loss of trust. A lot of unfinished business might be there, which only the patient might be knowing. The patient might want to visit a temple. You never know what the patient wants, right? It could be very simple things, but there might be a lot of they might need to write the will or something like that. We have seen multiple reasons when we like break the collusion, from their part. So these are some of the effects of collusion if the collusion is positive, like if the information is withheld. So both parties are grieving, but both are grieving alone. See, here the girl was also suffering, the parents were also suffering, but both were like suffering alone. When they came together as family, it was much better. The father was there, the mother was there, the child had support, they had support. They used to like, they never cried in front of her. But after collusion, the breaking of bad news, they like came together for this. Constant stress and burden of hiding the truth, inability to eat, sleep, and communicate with other patients feel out of control and trapped. So now we'll come with the case discussion. Amrita, 65-year-old female, has been diagnosed with CA ovary. Sanjay is her son and he has come to meet you. Okay, he appears confused and restless. He do not want to reveal the diagnosis to his mother. How will you handle Sanjay? Yes. So anybody, you can use the chat box as well.
Ma'am, first we can just ask Sanjay what is the reason for him not revealing this diagnosis to his father, who is the father or mother. Then, first of all, we should assess what is his knowledge about the illness, its prognosis, and then we can counsel him accordingly, I think.
Thank you so much, Ashwati. Exactly. We need to obviously we need to assess his insight, and we need to assess why he is withholding the information, why he does not, what are his fears, what is it that is holding him back from saying, what is it that he fears will happen if the news is conveyed. So we need to assess that. Right. Acknowledge collusion, explore reasons, just as she has mentioned. With the relatives concerned, elicit worries and questions regarding the illness. What are their worries? Why they are concerned? What are the fears that they are having? Ask, let them probe into it, give answers wherever possible. Feedback to the relatives regarding the awareness of the illness and readiness. Explain to the relative the importance of reassurance and honesty, why it is important. Explain it to the caregivers. Encourage dialogue between the patient and the caregiver. Ask them to have the conversation. Only if they are saying, I won't be able to handle this, maybe the team can take over the job, then we'll be like, if they are willing to break the news themselves, then it is well and good. If they are not willing, if they need our team to be there, then we can break the news. Okay. Right. Remember, value statements by family members. We need to take into consideration their opinions. If they are saying no, even if the patient is saying no, we should stop then and there itself. We cannot, even after giving the warning shot, they are saying yes to the information, we can give the information. And if the patients are saying no, I don't want to know anything further about this, then we don't force the information, right? Listen to the family members. We need to take into consideration the family member, understand who the patient is as a person, as well as who takes the decisions in the family. We need to know the basic family dynamics. Elicits questions from the family members. Review. This is more like personal. Okay, you need to assess about yourself. Did I listen? Did I explore their beliefs? Did I do my work well? Did I make an acceptable working diagnosis? Did I share options for investigation? Like this is more for the physician's part. Okay, we need to look into ourselves. We need to contemplate. We need to sit with these questions. Did I share in decision making? Did I give all the alternatives for them? Did I make some attempt to see that my patient is understood? From my part, did I do my work? Did I develop a good relationship? Right. So what are some of the take home messages? Best learned through experiences. Identify our skills and try to refine them. So this happens. This is a skill that you need to cultivate. You learn with experience. Identify our shortcomings and try to overcome them. See, nobody, even if I'm taking the sessions, I won't say that I'm completely perfect in breaking a bad news. This comes with practice. There might be certain errors, there might be certain things that will come up. There might be certain things that will come up during the sessions that might be very new to you. You learn each time you break a news, etc. There are no fixed guidelines. These are just protocols that we usually have to follow, right? But there are no fixed guidelines. Should be patient-centered and context and culture-oriented. As I said, in the Western, it could be entirely different. But when it comes to Indian context, when it comes to your context specifically, it could be different. So you need to alter it accordingly, accept limits. We cannot completely cure. You cannot completely take off the suffering from patients. We need to accept our limitations also. There is no role model. Never ever assume anything from the patient side or the caregiver side. With that, we come to the end of this slide. Any queries, anything related to this? You might unmute yourself.
Thank you, Rajika, for the wonderful detailed presentation. So we can take a question after the case presentation, I think. So we can move on to the case presentation.
Okay, ma'am.
Thank you.
Mr. Annamal Anthony,
Yes.
shall we start?
Can you hear me?
Yes, you are audible. You're audible, sister. Yes.
Good evening, everybody. I'm Sister Annamal Antoniswamy from Gujarat, South Gujarat. near Tapi districts. Our center name is Jeevan Vagal Bardipada. My patient is 59 years old, male, diagnosed with moderately differentiated squamous cell carcinoma of scalp and the lungs. The presenting complaint he came to our center was the following: small swelling and carcinoma increasing in size over the occipital region, and complaining of mild pain, occasionally fever. He also had headaches. Above, these complaints were present fast since 15 days. History of illness. His surname is Konkani Sajnubai Jumabai, 59, here I have written by mistake, 59 years old male, came to our health center with his wife and son Ashish Bhai with the following complaints: small swelling and increase in size over the occipital region, mild pain, occasionally fever, headaches. He also had a habit of chewing pan masala and smoking. And examination: weight 48 kg, temperature 96.6 degree Fahrenheit, blood pressure 150 by 100 millimeter of mercury, pulse 100 per minute, respiration 21 per minute, saturation 98%, and general condition he was quite good. Treatment and significant investigation. HB was 10.8 gram per deciliter, RBC 4.18 cubic millimeter, platelet count was 5,24,000, and PS smear showed that leukocytosis, eosinophilia, RBC cause, anemia, and microcytosis, thrombocytosis. ESR 8 per minute, RBC 102 for milligram per deciliter. His creatinine was 0.9 milligram. And a further investigation was done for him was histopathology. It was done outside. He has brought the report to us. Scalp lung excision was done nearby the city. That showed moderately differentiated large cell keratin type of invasive squamous cell carcinoma grade 2. X-ray of skull anterior AP view showed left parasagittal posterior parietal osteocystic lesion with erosion of table and overlying scalp swelling appears malignant. Down. PET scan. PET scan increase FDG up to uptake is noted medium in soft tissue lesion measuring 4.0 into 3.2 centimeter, causing distatic lytic changes in underlying parietal bones along the sutures extending. Okay, I'm not able to read that. The psychological aspects. A 58 years old man got admitted to 58 years old man got retired from the gardener work from the place where he was working in December 2023. They are tribals belonging to a Tapi districts. He is living with his children and his wife. He has got two boys and two girls. And among the girls, the elder daughter got married. She is very poor at present. Got married. He is very poor at present. The family is not affordable for the treatment. The family members and the patient did not know about the his disease condition. It is known to only the elder son knows a bit of it, not very much. The sons are not educated. They do not have a big job. They depend on daily wages. On the whole, the patient and the caretakers are not known the severity of the disease and the prognosis. Medication, he was getting TAP Clavivax, that is Augmentin, 625 mg BD for 15 days. TAP Pantoprazole D, BD for 15 days. TAP Tramadol 40 mg BD for 10 days. Syrup Leaf 52 10 ml BD. TAP Diciform of HS syrup multivitamin 10 ml BD. That's the treatment he was getting symptomatic. Main concern was swelling on the head, not able to go for the work, disease condition, new symptomatic treatment, and the prognosis. Summary. A 50 years old man got retired from the gardener work from the place where he lived in 2023 December. Is a tribal belonging to a Tapi district. Is living with his wife and children. He has got 2 boys and 2 girls. Among the girls, the elder daughter got married. He is very poor at present. The family is not affordable for the treatment, and he is diagnosed with moderately differentiated squamous cell carcinoma of scalp and the lungs just 2 months back. Now the patient is at home. They are not doing any aggressive procedure and the treatment to the hospital. Patient is very much worried about his disease condition and not able to work and support the family, and is depending on others for his activities. Discussion point. Does the patient need palliative care? How to explain to the patient and the family members the news and the disease condition? Thank you.
Thank you, ma'am, for the excellent presentation. I hope this presentation is clear to everyone. So we can move on to the discussion points. Anybody wants to need any clarification, please ask there. Please put your questions in the chat box.
Does this
So-
patient need palliative care? Please use the chat box, obviously, right?
Yes, patient needs palliative care.
Yes, thank you so much. And how to explain the news? That's what this whole session was about, right? The whole process, I think, would have been, if at all there is any doubt in that, in the way that we communicate bad news. Yes, yes, sister. Sorry. So, right. Any doubts with this case? The patient obviously needs palliative care. That's very evident. There might be a lot of psychological, spiritual issues with the patient, and how to break the news is what we had learned in this entire session. Clear, right? Thank you so much. If at all there is any doubt, please do use the chat box. We have a video which is related to communication, which I was supposed to show in the previous session itself, that involves mostly about basic communication. It could take
Yeah.
about 7 to 8 minutes, right, Shiba ma'am?
Yes, yes, Rajika, before moving on to that video, I would like to ask one question.
Definitely.
So why this patient is not taking any treatment? So that is, I would like to know why they are
It was
refusing
mentioned
the
in one of
treatment,
the
or
slide. It was mentioned in one of the slides that no aggressive treatment, right? Yeah.
because of the financial status?
I think Sister Annamal is Sister
It must be
Annamal.
due to the financial.
Oh, financial. So that we need to look into. So if there is any possibility there, we have to identify some source of income and support this patient. If there is any chance, there definitely we need to uh, find out the support groups. So, what do you say, Rajika?
Definitely, ma'am. So we need to address the concerns as to why the patient is not undertaking any treatment, whether it's financial or whether he does not want to. What the actual reason is, we might need to explore more. I think Sister Annamma is not right now in our video, ma'am, or she's not. Sister Annamma. So we might need to explore more on the reasons of why he is not willing to take treatment, and if at all it's financial reasons, then we might need to find sources or support system for the patient from our end, and or if at all it's psychological, or if at all it's any uncertainty that the patient is having, as I mentioned in the session, as I mentioned in this session, we need to address that also, whether it's any uncertainty, whether he has fear or any other factors that is like stopping him from taking the
Yes.
treatment.
Okay, thank you. We have to look into that part also. That I want to say. Anyway, we can move on to the video.
Right, ma'am. So I'll be just showing a video of the communication thing. We'll start. Okay. Shall we wind up?
Thank you, Rajika, for the wonderful session. Thank you, Sister Anamal, for the case presentation as well. Thank you all for participating in this session. Thank you. Let's see in the next session. Bye.
Thank you.